right, so we're going to start our last session. Again, fostering connections between classroom, sports, and healthcare. When reviewing this with Ryan and going over, at first I thought this was going to be kind of more challenging. The other two are a little more directed. We kind of understand it. It's we know what we're looking for. This is it. It's a little more vague, right? So, but I do think this is really important because probably this is where we end up with the most challenges. So not a big version like policy and administration, but actually taking care of people and how to help people navigate the system. And I want to use air quotes with the system because what does that mean? So Judy, I'm hoping you can start with, I'm just going to lobball, here you go. You know, you've been working in this area for quite some time. I know you're very passionate about it. And you see some strengths and you see certainly some weaknesses and some places where we need to change some stuff. Can you elaborate on that a little bit?
Well,
what is the system? Can you define the system?
So I kind of got into doing this because I started out as a clinician and I was a clinician researcher, but I kind of got into best practice guidelines and system evaluation because more and more I was realizing the system was broken. So when I say the system, what do I really mean? So there's healthcare, we understand that, right? The emergency medicine, hospitals, primary care. But there's also the community support system. So there's a healthcare component to that, but there's also social support as part of that. So for me, when I'm thinking about the system, you're not just a one health condition, right? You're a complicated individual with all sorts of facets. So it's looking at that time of injury all the way through sort of long term. So I don't just work with folks in the concussion space, also with more serious injuries like moderate severe brain injury and spinal cord injury, which are more chronic. So people kept coming time and time again and saying that they had a hard time finding the right care. They had a hard time figuring out what was the right advice. They would go online and they would read a lot of different things to do. And they didn't know what was the right thing to do. And that their family physician and the emergency physician and maybe the physiotherapist were all giving them different advice. And they didn't know who was right and what to do. And so myself and the team of people I work with just said, well, we need to kind of get into this space to kind of help people understand what that right advice is. So as Steph was saying, I've been doing this for a bit, and I would like to say that we've solved all the problems, but we have not. It's actually pretty tricky, right? It's pretty tricky because people fall back on what they were trained in school. They fall back on what they believe is appropriate for their scope of practice, and they don't really see how it fits in, to the larger picture. So we've been really trying to dispel some concussion myths, in terms of our work, trying to make sure that people understand what the difference between good advice and bad advice, right? So I think those of us who are here probably have a good understanding that sitting in a dark room until you feel better is bad advice, right? But there's a lot of people out there that don't know that that's bad advice, and it's hard to reach out to get that word out. So we've been trying. It's hard. With the neurotrauma care pathways, the goal of that work is to have a clear care pathway so that it's very clear. This is where you're moving through. This is how you can access clinical practice guidelines that are living, so they're continually renewed, right? So that people can go there, they can get those quick resources, the infographics that clearly say, do this, do this, do this. These are the things to look for. So, that's kind of like the high level of what we're trying to do. It is very difficult because we do not have strong policy leadership from the government, from Ministry of Health, to guide what we're doing. So people don't feel compelled to listen to us, right? Like if there's policy, then that creates the standard that people have to meet. Rowan's Law is a good start, But even there's issues there where people are going through the motions and they're not really internalizing what it's saying, and that there's a lot of follow through that still needs to be done. So policy, we don't have policy. We don't have a strategy for brain injury, and that's an impediment at the moment. I think, probably most of us in this room, if you think about stroke, cancer, we might have had a connection to that. There's very clear strategy for dealing with cancer, for dealing with stroke. When you get that diagnosis, the caregivers know what to do, right? Healthcare knows what to do for the most part. And we don't have that with concussion and with brain injury and with spinal cord injury. And that's a problem. If we had that, it would be a little bit easier, because it would be easier, like for you as a family physician, like I don't worry about you because I know you're informed, right? But there's probably a lot of your colleagues who are not informed, and without that kind of policy or formal strategy, they're not feeling compelled to level up.
Right. I agree. I certainly think that's an issue, and like trying to motivate people to do little tidbits from a primary care standpoint of trying to learn what is the newest stuff. And things are changing too, right? Those every few years there's new information out there, and trying to stay up on top of it is always a bit of a challenge.
Yeah, I was just going to say that so much of this needs to change, and Judy's doing some beautiful work, and so are so many people building the bills. But it's also okay to look at the people who you're working with in the room and say, this is hard and this is new, and you're going to skill it. Because life is skill, and we expect adults to be skilled at everything in the world. But if it's your first exposure to something, it's going to feel scary and it's going to feel new. And you will become more efficient and you will learn. So I think it's important to empower people and to say that. So my basement flooded a couple months ago. It was atrocious. I had no idea. I walked downstairs, it was a mess. I didn't know who to call. I didn't know who the experts were. I didn't know anything. And that moment was really terrifying, right? It's going to cost me a fortune. I don't know who to talk to. Like, this is what it can feel like if you are navigating something new and if you're exposed to something new. And I think we don't acknowledge that very well at the beginning for people. And to say, I will help you and I'll help instruct you, but take a beat and you can learn this and you will learn this. And even as a parent, be a little vulnerable to your child that it's new, because they're going to watch you skill in and they're going to feel comfortable when they're faced with something new. This is new for my parent. They learned how to do this. This is how they made the phone calls. This is how they did these types of things. You shouldn't expect yourself to be an expert. I am considered one in this field and I'm still learning how to navigate it. So I do think we have to come to it from both angles and help people skill in, not just get it done for them too. So just another kind of message for...
Oh, yeah, that's a great message. I want to come back to you, kind of the set pathway, and I think your hand motion was linear. And I think most of us in concussion recognize that it's not linear. So the pathway is not linear, but nor is it, because it's not just one issue, right? And one thing, Shannon, I was hoping that you could breach up on is that, I always liked the CAB, like the parachutes diagram of having, I always think of family medicine as being the quarterback for a lot of care, right? Not just concussion, but whether it's cancer care or whether it's heart disease, like we're usually sending people in and out and need to have a finger on pulse for multiple different services. And I like that with concussion care. The one issue I have with that diagram is I think that's important because concussion is not one symptom. Is it psychological? It's probably all of them, right? So is there a sleep component? Is there physical pain? Is it neck? Is it headache? Is there cognition? Is it memory? All of these things. And each will have someone who is more qualified or interested in helping those symptoms. The one problem I have with that diagram is that it has a physician in the middle, whereas probably it needs to be the patient in the middle, right? And then going with help from whoever it is and guiding, hey, how about for, your neck issues and probably some tension, headache concerns, we're going to go this route. Can you talk about that component of integrating a multidisciplinary team, I guess?
Yeah. No, no, no. It's a wonderful question. And look, people's experiences and their own psychology, not as a field, but as who they are as people, end up sometimes being the thing that guides some of the symptoms that people are experiencing. So, for example, you have somebody that has a really high cognitive job, and their job is to make a lot of decisions and to synthesize a lot of information. Often they'll come to me with these cognitive symptoms. They focus on them. It's a big piece of who they are. The same way that the athletes are really good at reading their body and understanding their physical pieces. So I think it's really important to understand who's in front of you, what drives them, and what is important to them. Because sometimes they'll push away those physical things because the cognitive ones are the ones that are right there in front of them because they need it the most for their job, or they need it the most for their school, whatever it might be. So you have to take a beat and ask who this person is that's in front of you. The other thing we like to do with concussion is to make it a bit of a monster. Like it has the ability to think for itself and it has the ability to do things to people. It is an injury, it is an experience, and it is an incident. The only thing that has the ability to drive your car and to cause some of those symptoms to really kind of grow and evolve is you in the driver's seat. And so it's important to help people reclaim power so that they can get better and they can move on. So take a moment and ask the person simply, who are you? Why did you come here? And that's often a question that I'll start with. Like, you're here in front of me, who are you? And it's amazing how many people will say, oh, I'm a student, or I'm an athlete, or I'm a daughter, or I'm a this. And people will define themselves to you, the core inner things that make them who they are. And those will be the goals that you can start to set with people to direct out. So it's not that any one bucket is more important than the other one. It's just what is important for that person. And that takes, honestly, 3 minutes, 5 minutes. We're not saying that it needs to take an hour. You mean a full psychological intervention for something like that. But it's a really good question to start with instead of what are the symptoms you're experiencing. Like, who are you and why are you here? That's where I start.
And just to add on to that, I think, so I've been involved in the teams that develop the best practice clinical guidelines, right? And so I think it's important to remember that there's not a special concussion headache. It's headache. And there's not special concussion anxiety. It's anxiety. And it's not special concussion depression. It's depression. And there are clinical practice guidelines and clinical strategies for dealing with all of those symptoms. So I think that's important to sort of think about too, is knowing the person who's sitting in front of you and realizing the best person. So to your point, how are we doing this multidisciplinary care? Is the best person to provide that. So it may not be a multidisciplinary concussion clinic. Not everybody needs a multidisciplinary concussion branded clinic. It may be that they need, to be seeing someone for anxiety what they can really connect with, and that's the person that's going to help them best. And the family physician can maybe open the door to make a referral into that. It might also be the family physician, depending on their area, if they have a focused practice or an interest. So I think we have to be really focusing on those individual needs. And also, if you go to the concussion guidelines, it's going to reference you out to the clinical practice guidelines for depression and anxiety. It doesn't create a whole new guideline for doing that. So I think that's the other piece to remember is not everything stems from the concussion either. There could be pre-existing things, but there could be things that had happened maybe at the same time or soon after the concussion that are actually the root cause.
I think in most things in care, I think physicians should and try to, we talk about treating the person as a whole, right? Like that's the big thing. You can't put someone in a box, and there's all kinds of different things. And I would think about it like if you have a tank filled with water and that water we'll call headache, that's the symptom. Okay. Well, we're going to concentrate on that. And then as that level of water flows down, all of a sudden there's something underneath there. There's the next problem that we didn't get to, right? Because there was the other stuff. So now we are like, okay, well, we've got headache under a little bit of control. Now we can aim for that one because that's causing more symptoms, and it's just chipping away at those things over time. So that's the way for system-wise. I think that's how I'd like to see it. Now the problem is going to be the integration and the communication, right? And sure, a gold standard would be, a concussion clinic, multidisciplinary concussion clinic that has all of these things. And I think realistically, that's not going to happen, right? That's very expensive and very challenging to find the resources to do that. But having organizations and networks of people, that's a little more reasonable. So I'm not sure if that's a road. I don't know if anyone wants to speak to that about the networking piece. Yeah.
So maybe I'll just jump in and kind of reference a little bit of the part of the system that I believe I'm here to represent, which is sports. And so one of the things that I'd like to point out is, unlike education and unlike healthcare, our sector is primarily volunteer-led. Yes, there are paid sport administrators that are out there doing amazing work, but the majority of the sports system, and I'll extend this into the physical activity realm too, because I think that's an important part to discuss as well, is volunteer-led. And the leaders, we call them sport leaders, or very often the reason why I'm here is coaches. Coaches start to become that connection piece, because they are the individuals that are very often with those individuals, maybe not every day, but very frequently. So the role that coaches end up playing in connecting can be really, really huge. And so that's what we're trying to do, is we're trying to make sure that we resource and support them so that they can continue to play that vital role without being overburdened, and also, recognize that maybe they're not an expert and that they need that support from a professional side as well. But for us, it's really about resourcing them and getting into the right places and starting to talk about those trusted sources. And I know we'll dive into that a little bit more.
I do think that's a really important part, because for many people, a coach represents their point of care almost, right? Which is good and bad, because one, I think there's a lot of potential there. There's also, unfortunately, if whoever the sport leader isn't informed, and I think your organization does do a great job at, with the Making Headway and the various courses that are mandatory. Every time I've done those, really, how do I gotta do this again? And then I do it, and I'm like, this is actually pretty good, right? So, I applaud the Coaching Association for that, because I think for a lot of people, and it is practice, right? The more you get exposed to it, the more every time you've done it once, like, okay, now I know what to do about a flood. Next time I'm going to call this guy. Well, hopefully it does now, right? Yeah.
If I could just jump in. So when I'm trying to make change broadly in the system, who are the people that I focus my efforts at? Well, I can't just focus them in emergency departments or primary care physicians or, healthcare professionals and community. I also have to focus on coaching associations and schools and teachers, and because those are the folks who are on the ground and have those relationships, and that's why it's also really important to have all of this information publicly available, freely available, so that people can. You can say to your members, you can go to this is a trusted source. And as a coach, you're trusted by the athlete, but then you have a trusted source that you can go to count on that information. So that's the other piece that is really important in the world that I'm working on, is getting people publicly funded healthcare access. I mean, no disparaging to the folks that are fee for service, but we have to make sure that there's that base level of care that's available to everyone through the public funded system. And so that's part of why we're making everything freely available with our best practice guidelines and with the information that we have about care pathway and those essential building blocks of care, because you are our knowledge user as a coach, and teachers are the knowledge user, parents, healthcare providers. Like it's a web of people that need to get connected, and they're not naturally going to be connected.
So, and connection to me means communication, right? A big part of that is what's going to be the most efficient way to do that. Now, clinician wise, that's a challenge. I don't know why that challenge. From as a clinician hat, what do you think the best efficiencies are in organizing that type of communication? I don't know if is it we need to have all these people in the same room, or is it just sending faxes, or is it emails? Like how do we do this?
To connect the concussion system clinically.
Yeah.
So, I mean, we can all pick away on all the challenges that are there. I think a lot of things get down to trust and how somebody conceptualizes and if it aligns with you. So I will say, if you haven't tuned into any of the echo models that are available for many different conditions across Ontario, that's a really good way to see people that are sitting on a hub or people that are even attending that might be really interested in the topic that you're interested in. And you can present cases there clinically too for people to give feedback. So it's a quick hub and spoke model. I really like it. I like participating in it and I learn from it often. So I think that that's one of the ways to connect. It's also okay to admit especially if you're in primary care, that just like I said with the flood, we don't expect you to know everything all the time as far as connecting things. Your job there is to help people recognize and then facilitate some of those conversations. So I always wonder why we don't have navigators for the clinicians too. We have so many, and we're thinking about it for families, and it's so important. But we need that type of connector for our clinicians that we can call in and say, I've recognized these things. I have these ideas. Who should we send them to? Because that will help connect the system, right? You cannot, as a family practitioner, be aware of all this. It's changing so fast in every single discipline. And in this one is really a challenging area because we haven't mentioned it today, but there is that concept of predatory practice in concussion. It started to really evolve in awareness when private care started to pick up. And most people will get better from their concussion. So we do have this idea where people could potentially make money, and a lot of money, off of something when somebody's going to get better anyways. So I'm not saying don't be a quarterback and don't be there and don't facilitate things, but there is something when people start staying unwell to stay in the system and people make money off of that. So I think we have to recognize that there is this component, and Canada is particularly set up to be really naive in this area because we are just starting to even kind of admit that we have a private system. We do have a two-tier healthcare system in this country. And we don't get any education for people doing that. So I think that's another thing that we need to think about for clinical and healthcare navigation is that this one is new for navigating this two-tiered healthcare system. And we do need some support and learning for our clinicians. So I think it should go right into our training programs where we start to talk about this.
Yeah, and I agree. And it should be put into, and I think back to med school, and there was not a whole lot there. Right? You get one talk or whatever, 2 talks on it and carry on. And we know that information changes very, very quickly. So also from a coaching standpoint too, because if coaches are going to be at one of these hubs too, staying on top of that information, and where do you find the challenges are for that and making sure that people are up to speed?
So officially, there's 2 major intersection points with a coach in the medical system, which is the diagnosis part and then the clearance part, right? But that's just a very small picture of really what a coach is going to do in the concussion management protocol. One of the interesting things that we've kind of found out through our research over the last couple of years is that coach awareness for education, concussion education, is starting to outrank that of their athletes and their parents. So now coaches are playing that role as an educator in the system. So they are becoming a trusted source. It is another demand of those coaches. Unfortunately, we do have some resourcing for that. But for them, they might need to be seeing them. They might see them, when it first happens, and then they might not see them for a couple days. So it's really about, putting that athlete in the best position to say, okay, here's where we're at. This is where I know you're about to leave my situation, but this is what I'm hoping is going to happen by the next time I see you. And so that's clear communication with the athlete, and then obviously depending on the athlete's age, with their parent as well. So if we're educating not just the athletes about potential symptoms that might spring up, but we're also telling the parents too. And then what we would expect for them to do between the next couple times we see them. And doing those check-ins, like coaches, we want to check in with our athletes on a regular basis, see how they're doing, if it's diagnosed or not. And then if it is diagnosed, okay, this is the plan we have in place, and having those open and frank discussions about what this could mean in terms of playing time and all those things.
Yeah. And I know Scott talked on a little bit about, communication with, especially with parents with younger athletes. I know you guys do some emphasis, have some information on that. So can you go into, we know that there's different types of parents who are going to react differently. And are there strategies and a communication from a coach with their athletes and the parents that are better or worse?
So the number one thing I'll start with is early communication. So this is something that we don't want to have dealing with, for the very first time when it happens. So your example is, well, we want to be talking about floods before the flood happens. Well, we want to be talking about concussions before a concussion happens in our settings. So there's a shared expectation of what might happen, and a shared understanding of what the process might look like. And all of it's highly contextual, but you want to give everybody sort of a footing at the start. And that can help tremendously in those conversations between coaches and athletes and parents before it even happens. So that's number one. And then I would say that it really depends, but you'll have different experiences. Some parents may have dealt with this personally, or they have another child that has dealt with it, and we've had some examples of that today, so they might kind of already know exactly what's about to happen. And so for a coach, then it's about supporting and monitoring and guiding through the process, which is an ideal scenario. But then there's also maybe this is the very first concussion that a family has ever dealt with, and maybe they need more additional support. And maybe that goes beyond what a coach can provide, and then they're looking for those practitioners that they need, those experts to step in, especially in any situations where it's not resolving in the usual fashion. So those are the big ones, I would say, for coaches. In the worst case scenario, it might be a managing conflict situation. And that stems from, passion, a desire to want to play, because it is not a fun, no coach wants to be in a position where they're telling someone they can't participate in the sport they love. But we want to make sure you reframe that and say, we want you to participate in the sport you love, but we want it to make sure that your health is first and foremost. So that's definitely another scenario that we can face.
And I think it was Paul has mentioned too, I really appreciate the idea of that coaching needs to provide that safe space, regardless of what it is, not just concussion wise, right? But for all injuries, health concerns, things that happen at all, right? That should be part of the job and responsibility, even though it's volunteer. And that's a good point. A lot of these people are volunteers who have other full-time jobs, and just they're hoping to provide some knowledge and help kids do the stuff that they love to do. So, trying to think.
Just while you're finding your notes, I think the other point to mention is obviously, as a parent, if your child has experienced a concussion, it can be really scary as a parent to see your child suffering. And if they have a lot of cognitive symptoms, it can be really scary. And it's natural as a parent to be like, I have to step in, and we have to be actively doing something, and doing more of stuff is going to be helpful, right? To kind of make the child better. And one of the things when I've talked to parents is sometimes more therapy, more treatment, more working on it is not always the right thing to do. I think you have to have that sitting back and going, is this helping? Are we getting at the root cause of what the problem is? And it's okay to be like, I don't think that particular treatment is working. Let's stop that and maybe try something different. And it's not working, so we have to try more of it. And I think that gets at what Shannon was saying about concussion can be a little bit predatory, is that sometimes the solutions are seen of just do more of it. And I think clinicians and parents and coaches and everyone, have to have the wherewithal to say, it's okay if this particular treatment isn't really working, or we can take our treatment holiday, or we can do something different, because that's okay. We don't have all the answers all the time, and everyone's an individual, and we just have to really be looking at the person in front of us. And I've advised people, I've had people call me and say, I've spent $40,000 on my treatment after concussion, and I'm going 5 days a week for treatment, and I'm not getting better, in fact. And I would say, do you feel the same or worse? And they would go, oh, it's worse. It's just not doing well. And I advise them, well, why don't you take a treatment holiday? I'm not saying no more treatment, but why don't you take a treatment holiday for a couple of weeks? And they would call me up afterwards and they say, I feel so much better. And I went, okay, so let's unpick, what you were doing and really help you do what's right for you and your symptom profile. And that's challenging to do that, right?
Yeah, absolutely. And I think that, there's still so much research going into treatment modalities depending on both diagnosis and treatment modalities, and what are the best ways to do it. And we've all, I think, agreed that it's going to be assessing what are the concerns that need to be treated. Do you have something to add? Because I was going to go into the research, because I think this leads towards research, and that you're all involved in research, and hopefully that's going to provide some of those answers in the future.
Could I mention the education sector
Sure.
quickly
Yeah.
before we do that? Are there any educators in the room right now? I see some hands go up. So first of all, I think as far as kids, you have one of the hardest jobs that is going right now. You are frontline for everything in a way that I'm guessing you didn't expect to be when you first went into this field. It's changed so much. And I saw that a lot during COVID, when we had people parachuting as experts into the education system more than we experienced in health. We did not have people coming into health telling us what to do. You have people marching into schools telling you in your area of expertise what to do and how they knew how to do it better. And I think it's because everybody went to school. So everybody thinks that they're an expert in school. I think you are. I think I have things to offer that can help and support you in school. But I believe that if we're going to help these sectors, we have to promote people's expertise, and that means acknowledging and promoting yours. And saying that in the system and in the classroom, I am not, as a psychologist, an expert in that classroom, you are. So how do we work together to help this child in that environment, from the things I know and the things you know? We are hesitant, and to a degree that's unfair, to give teachers the label of experts, and you are. And so I think that anytime I get the mic and have the opportunity to say that, I think it's really important to acknowledge that. So it would be great to be able to work back and forward and say, what do you see? What are you worried about? How can I help you get that done? Instead of just writing a note and expecting you to get it done. So I just wanted to say that, because we didn't even acknowledge the education system up here. And it's not lost. I mean, it's not just concussion, it's mental health, it's everything physical, it's every physical health condition, it's parents like me ruining things for you guys. So I think that you deserve and should have a space on this couch. You're a huge sector for these young people. Little soapboxing, meant to have you.
That's very good. I like it. This is what we're here for. No, that well said. You're right. Like we even, for the future, I should go and we were talking about how directing this, for the next few years and how it might change and the audience may change, and maybe that's one area where we end up tweaking things a little bit. Can we talk about research a little bit? Because not the nitty gritty, but the role of research in the area and how we can use that in one best knowledge translation. How do we get it out there for everyone, and what we should be doing with it? So, what we start? Yeah, go ahead, because I know that you're right in there. So,
And the research. To let you guys know, we don't want to talk a lot about all the method stuff, but research itself is changing as a sector. So we used to do this thing where we would make sure everything was tested perfect in our labs and on our ivory towers, and then try and roll it out in the real world. And things didn't work very well, as you can imagine. And now funding agencies are starting to change and say, can we test in parallel? Can we test in a more generalizable way, where you're thinking about a treatment or you're thinking about something that's happening with an assessment in the actual environment that it's designed to be in? I know that this should not sound shocking, but it actually is shocking. So we're starting to do very different types of trial designs where we're trying to increase that amount of generalization in research. So the hope is that we will narrow this gap that Steph is talking about, of this idea that this ivory tower research gets rolled out. It should also mean that the research should be more meaningful to people in their everyday use. And I think that actually gets down to cross-sector, right? We need to be able to do some of these research studies in the schools, in the clinic, in order to navigate and see. And when we have treatment for conditions that are wide-reaching, like concussion, like brain injury, where there's a lot of different kind of buckets of symptoms and experiences, we do really need to test those live and online for people. So I think that this system is getting better at asking questions in a really good way. And I feel really lucky to be in it at a time where we're starting to change that. So that, I think, is one of the things that's coming that's really hopeful. The other thing that's been good is that we started to ask people what they expect from research and what they want done. So it's not just me saying, as a researcher who's read the evidence, this is the next question. Yes, what I've read and what I've learned matters and my expertise matters, but is it aligned with what the system needs, what the sector needs, and how do we test that? So how do we see that we made a change there? So I think that these types of trials are really cool, and you're seeing it in drug trials and treatment trials and a whole bunch of different areas coming together in a multidisciplinary way. So it's
is
possible.
that somewhat controlled by funding, though? So bigger picture, but so
Everything is.
well, right. So, but if it's funding coming from people, I guess I wouldn't want it to bias the research, right?
Yeah.
All of a sudden you're like, well, here's what we want to know. We're going to give you money to go and find that out. Even if it's not the results they would like, it's still somewhat biased.
Yeah, I think it needs to triangulate. So when you're looking at the national funding bodies in Canada, you have to have multiple reasons for why you're laying out a study and you're asking the questions, and what people want and what they're experiencing and what their experiences are is a good reason. What's in the literature is another one. There will always be foundations that drive some research projects. And so we need to be very transparent if you're funded by somebody like this. And you'll see those disclaimers now before talks, right? I mean, I'm funded by this agency or I'm funded by this foundation. So I think as consumers of information, we always need to stop and actually take a moment and look at those disclaimers. Did the tobacco industry fund your tobacco trial that says chewing tobacco is great? Like, maybe you should look at that. So I think we need to inform both ways around. But we'll say that for some of the bigger national bodies, you have to have more than just one group saying, I want this. You have to kind of have a lot of different rationale for it. Yeah. It's a really...
And I think funders have diversified, right? It used to be that there were certain types of research that just plain weren't funded. And I think now the funding bodies are getting better at funding a range of research that really matters to people. So that's a good thing. The flip side of that is when the adult concussion guidelines wanted to do an update, they had to read 22,000 research papers that had been published since the last time they did an update. So I think we can all get that 22,000 is a massive number. And so when you talk about how we can get the word out, part of it is you have busy clinicians, like you're not going to read 22,000 research papers on concussion to tune.
I serve my thought.
That's right. And no clinician is going to do that. So that's why it's good to have living clinical practice guidelines, because they have the infrastructure and who then they're not biased, right? And they're going to review all that to distill it out into those key messages that are the most important to get out there. So to me, I mean, my bias is I'm part of the team that develops these living clinical practice guidelines. So fine, I champion that. But I honestly believe that that is the way to go, is that they distill the research, they put it in a way that's usable and digestible to busy clinicians and to members of the public to get out those key pieces of information. And then they're living guidelines, so they're constantly sort of looking at what's coming out, because research is always changing. Like always changing. You know, I mean, people said to me, is it boring to do research? I'm like, are you kidding? You have one question and then you answer that, sort of, and then it generates other questions, and then you go and you go and you go. So it's really exciting, but it means that we have to keep being open to having new messages and new changes. So braininjuryguidelines.org, but that's where you can go and get access to that up-to-date evidence that you cannot expect clinicians and teachers and coaches or anybody to stay up to date on.
Well, and I think the Coaches Association has a unique position in that it is Ontario wide, and it's wide reach, and you guys are collecting data as well, right? And I think it's often on how has Rowan's Law affected how percussion care is being used. Can you elaborate on your newest stuff?
Yeah, so I'll preface this with like more research, please. That would be great if you're a researcher in the room, because we know that it's traditionally confined to certain sports and certain populations, and that's not helpful for the diversity of sport that we see in this province. So that's one big one. But there's really good work being done. When it comes to the Coaches Association, obviously we rely on the experts for, I would say, the big things, right? We follow the consensus statements. We go lockstep with Parachute and Holland, Bloorview and Sunnybrook in terms of making sure that we keep everything up to date and accurate so that everyone is singing off the same song sheet. Because I think that's one of the things that starts to get difficult if schools are doing one thing and then sport organizations are doing another thing and a parent heard another thing. So that's really, really important. Where we're kind of focusing our efforts in the research is a little bit of that culture change piece and how knowledge translation is working. So I shared a little bit, but we're asking coaches, parents, athletes, like, do you know about these things? And we're seeing that coaches are probably a little bit more informed than the athletes and the parents. And the reason why this is really important, and maybe I'll do a little extra audience engagement here, is like, raise your hand if you have actively coached at any point in your life. Okay, that's about right. Raise your hand if you've been coached by anybody in your life. Okay, so obviously more hands on the second one. And the reason why that's important is because we know that for most athletes, they view coaches as their second most trusted source outside of their parent or guardian. So coaches are aware athletes and participants are going for that information. So that investment in coach knowledge translation is really important. And we'll hopefully continue to see the research trend in a positive direction. I know that there was some recent news that Rowan's Law is showing that we're seeing decreases in rates. They can't make a correlation, obviously, but we're seeing some positives out of now the efforts since 2018, as was discussed earlier. So hopefully we can continue to see that. But it is culture change. It takes 5, 10, 20 years.
Sorry, you were saying decreased rates of diagnosed concussion?
Yeah, this came out right around Rowan's Law this year in September. So there was they're starting to see a little dip. Now that could be related to reporting. There's all sorts of reasons as we know, but they did make a mention that there is the timeline is in line with when Rowan's Law regulations came in place.
In all fairness, I'm optimistic if that's the case. Like, that bodes quite well because there is more awareness out there, and I think people are now seeking out more so. So if even with increased people be more willing to go be assessed and get a diagnosis if we're still having decreased frequency. I'm interested in reading that at some point. That's great. Is there any pressing things that you'd like?
You a question?
Uh-oh.
Yeah.
No, I'm not.
We're sort of thinking about navigating. So we've talked a bunch of times about the importance of going to your frontline clinicians, so your family physicians, nurse prac, especially for diagnosis. And then we've said, like, kind of off the cuff, oh, but we know not everybody has this. And we know that the rates are plummeting for primary care, right? That people have access to this. So for this particular field, what are we going to do when we don't have people like you for a lot of our people? And we already see challenges based on sociodemographics and based on a whole bunch of other factors. So I don't know if you can reflect on that.
That's going to take a long reflection. I know it is a good question. Unfortunately, it's the same for all new diagnoses, right? There's a dwindling number of, we know that people are not choosing to go into family medicine. I'm optimistic that's going to change in the next few years. Queen's Family Medicine residents, we had the preceptors had a getaway last week in a conference to kind of go over how do we help this? How do we teach? How do we encourage people to go into primary care? What will happen? I had a talk with our local MP 2 March breaks ago when I said, a third of Peterborough does not have a family physician right now, and I promised him that in 3 years there was going to be half that won't, because when I'd gone to Queen's Family Medicine Day with all the new residents, they were just about to graduate and none were choosing to practice in Ontario. It's going to get worse before it gets better. So now that's a different problem, but where would you go if you didn't have that? I don't know. Because so much of the information that's been over the last 10 years, the core idea is that primary care is usually going to be the quarterback of care. Maybe that's not going to be possible. And I don't know. I hope so, because I think that's the right place for it to be. But if there's not enough, then what do we do? And I don't know where that goes.
I attended a primary health care research day maybe like a week and a half ago, and Dr. Jane Philpott was the keynote speaker, and there were a couple of things that I kind of took away from that, and one of them is, okay, what do you really need the primary care provider to do in that role of quarterback, and what can be done by a family, like a primary health care team? Does it always have to be the physician? Can it be other people within that? And how do we support people to work better as a team at the primary care level? So obviously this is visioning, and this all sounds great when you hear it, at a conference, and they're researching these models. But the idea is kind of making sure that the primary care physician, the family physician, is doing the things that are truly within that scope, and they're working as part of a team. So there's other stuff that maybe you're doing as part of your practice that you don't necessarily have to do, but it can be spread to other people on the team. So this is how the thinking is to handle the dwindling numbers of people actually wanting to go into family medicine. So anyway, just because I heard this like a week and a half ago, and I think interestingly enough, we talk about AI, and the role of AI, and most of us who are clinicians don't like to think that we can be replaced by a chatbot. That's not what we want to be replaced by. But there are certain things that the research is showing that chatbots are actually really good at. In fact, chatbots can be empathetic too. And so the research is showing, I think we have to get good with the role of AI, in doing some things, and then other things need to be like an actual caring and empathetic physician too.
It's interesting because this I don't know what we call it. It wasn't a conference, but for all the Queen's Family Medicine preceptors, the big emphasis, all the talks were on AI and the role of education and chatbots and using them in clinic. And it was really quite fascinating. I thought that it certainly sparked a lot of interest in a lot of us. We're like, okay, there are some very appropriate and good uses to this. But the other part is that it was actually at the Queen's primary care research day where Jane Philhott spoke last year, 2 years ago, where everyone said like they're going to go east or west, and that was, it's a utopic world and idea of, I think the idea behind the community care, community health care organizations. I think there's there could be potentially a lot of benefit to a system, but we've tried those and they don't really work out because it ends up being a lot of more middle management, right? So people only do what they're right. You send people to where for that thing, they should go to this person, right? And I think it's important for people to stay in their lanes, but there needs to be also some people who are truly generous, right? Who can see the big picture. And I think that's where that position will be lost, unfortunately.
And there's a lot of like bringing back to concussion. It is a really vulnerable piece of our flow chart. That the first thing in is this diagnosis of a hard diagnosis. Concussion is actually a really challenging diagnosis to make because yes, you need the history, and sometimes it's very, very clear, but a lot of times it's not. And so it takes some experience, it takes some training to do it. We don't have a great marker. We have all these kind of challenges with it. And so if we have a breakdown at point A, all the other cross-sectoral reform will break down. So I do think it's a vulnerability for this field, and it's one I'm growing and concerned about. And so if anything, we can almost be advocates as a good case study and a good example for different ways to think about it. But it's in every single clinical guideline is number one. So just to kind of flow.
No, for sure. If step one is flawed, right? It's kind of hard to have the other stuff follow. And we're not at concussion is still considered a clinical diagnosis, right? There's no marker, as you said, Shannon, like where you can have a test and that will say, yep, you've had a concussion. So it is challenging to make that diagnosis. The American Congress of Rehabilitation Medicine has developed some diagnostic criteria for concussion. This is their way of trying to get some certainty, in the diagnosis. It's still a clinical diagnosis, but they're trying to put some more parameters on it and just sort of say if everybody followed this structure of diagnosing concussion, then it's a way of bringing some certainty and some standardization to an injury that is really very individual.
And we're more likely to call it in some situations than others. So if as sport-related, people are more likely to make that diagnosis than somebody that I've seen that had a slip and fall on ice in the middle of winter or a fall in science class. So I will see bias of population as well, which is a pretty natural thing with functional diagnoses. But it's, there's that.
Well, thanks for bringing that up, because one of the points I wanted to mention is usually when I speak to a group of people, I ask them to think, how do most people get a concussion? And often the audience will say sport, and I go, wrong. At every age group, the number one cause of concussion is a fall, right? And so it's really easy for us to think about sport and motor vehicle collisions as being the largest cause of a concussion, but they're not. And people get concussions from just living their life. And I think we also have to make sure that when we're working with folks, and just like we heard on other panels, the concussion could have happened, at home falling down the stairs, and now they're reporting to play, on their team. And so we do have to be aware of the fact that concussion is everywhere, living life. It can impact school and sport and driving and all of these other things, but we have to be open to that. It's not just something we have to think about in the context of sport.
Yeah, thanks. That's a great point. We're coming close to being at the end here. I just want to make sure that, is there any questions that pressing questions that people want answers to before we finish up? Connor,
Not really a question, more just a comment. I think, Judy,
you had your chance.
you just kind of breezed over like the braininjuryguidelines.org. You just kind of said it really fast, but it's probably like the most important resource in the province. So if anyone's got a pen and paper, like that's where all of the information is, and it's free.
Yeah,
If
so
you're a teacher, if you're a physio, if you're a doctor, it's all right there.
braininjuryguidelines.org. There are 3 guidelines up there: moderate to severe brain injury, adult concussion, and pediatric concussion that you can access. All of the both concussion guidelines have resources there for teachers and parents and coaches. And, Parachute is a good resource when you're thinking about sport-related guidelines and return to play. So these are your trusted sources for the best evidence at the moment. And more guidelines are realizing they're not just read by clinicians or researchers, they're read by just people. And so the guidelines are getting much better at producing infographics and lay language summaries and guidance. So for example, there's a do's and don'ts handout that I would love for every emergency room to have to send with their patients, every primary care provider, and it's just very clear things to do within the first 48 hours after a concussion. Do's and don'ts. Very, very easy. Anybody, can look at it. So for sure, thanks, Connor, for giving me the opportunity to highlight it. There's a few of us here, Connor, Shannon, myself, who are involved in the Concussion Echo, and that's a model for helping clinicians and frontline folks connect together on cases and education. So that's what we're doing at the clinician level. So there are some good things. I think the thing that concerns me is people who have a little bit of knowledge, they know that they don't know everything and they're hungry to get more. There's a lot of people out there that don't know that they don't know. And so it's the challenge of trying to get to those people who don't realize that they really don't know and that they need to level up. And that's the hard part. I mean, you must see it with coaches too, right? Like it's getting those folks on board. It's a challenge, and we haven't got the full answer to that yet.
That's perfect. Is there any other questions? I think we have time for one more.
With the topic of this panel being around fostering connections, I'm a chiropractor. I see concussions all the time and work with them. If I want to communicate with each of you, and if there's an educator in the room, what do you need to know? What do you want to know from us? How much detail? Like, how soon do you want communicate from us about what we think they're capable to do, where they're at in sport? There's lots of different forms that not everybody uses.
I think as soon as you can, when you've got something that's valuable to communicate with. And it's your job to pass it along as a clinician, but it's also your job to have conversation with families about how to use the things that you've produced so that they can use it and advocate within their care as well. So if I write a report, I spend a lot of time talking to families about this is what this report is, this is how you can use it, this is how you can share it, this is the language around you sharing it too, because families can navigate their own care and they are able to do that. We can just help foster those communications, right? So I do think a lot of it has to go back to the person in a supported and caring and skilled way. But anything you've got that you have evidence that can help support things, I mean, send it along as soon as you can. Yeah, I would say.
I know from a clinical standpoint, I always like receiving notes from people when they've been assessed. And then usually it's just a fax note saying, here's what I've found with this. They've presented with this. Like I've already seen them too. If not, then I should. And if I haven't used it'd be great if you can get them in for an assessment and a reassessment to see if there's other things that need to be, or is there other areas that I can refer on for or refer to. But also, here's what I've found clinically, and here's what I'm hoping to treat over the next little while. Here are my concerns. And that's, I want that from anytime I send someone to ophthalmology or ortho, like I'm hoping, here are my questions. Can you tell me what you found and what you would like me to do and what I plan to do? So.
The other point that I, just want to mention is that the forms that you have to fill out and the format of the reports, I mean, it varies depending on who's asking and in what sector that you're in. So one of the things that I'm trying super hard is working with the Insurance Bureau of Canada in the motor vehicle collision sector on trying to get some standardization for reporting, for writing reports, for communicating assessments, and for communicating care plans, because that's also part of the problem right now is you can have a one-sentence concussion on the report, that's it, or you can have a 20-page report that nobody is really going to be reading because it's 20 pages. So that's the other thing that we're trying to work on in terms of getting some standardization in the reporting and the communicating, so that the most important things that you just said, Steph, are clearly communicated, what people are going to want to know, and that care plans are defended and explained in a way that you can understand. So we're right now recruiting a couple of insurance providers and a couple of preferred clinician networks to work with us on that pilot project. So that hopefully will improve the communication as well.
Great. No, I'm looking forward to that. And hopefully it's not just family doctors they're the ones that can sign it.
It's all a process. We're working on it.
Perfect. All right. So thanks again for the three of you for your expertise in this. And I think Vince is going to come up and do a conclusion. Is there more food? Oh,
There's always food. Lots of it out there for you. Thank you again for being here. This is fantastic. Judy would say to Shannon, give him a big round of applause.
and Brian, there's some gifts for you as well.
On behalf of PACA, we want to thank you for joining us for the inaugural Peterborough Concussion Summit. Our goal today was to highlight the importance of collaboration between athletes, educators, healthcare providers, and community. And I think we've accomplished that today for sure. Once again, I want to thank our sponsors, Gallen Boris Injury Lawyers and the Ontario Brain Institute. And we want to thank you for being here today and taking part in this discussion. And hopefully you've taken something home of value today. Safe travels. And thank you again for helping to create a safer, more concussion-aware community. Have a great night, everybody.